My name is Fred Scheich. I'm with IFARA. We're here at the 22nd CROI with Mary Glenn Fowler, who is with Johns Hopkins University in Baltimore. And we appreciate her taking the time to talk about the PROMISE study. So if you would be so kind as to give us a background on the PROMISE study.
Right. Well, it's a pleasure to be here. And the PROMISE study is a large study which has been going on for the last 4 years. And it's taking place in 7 different international countries in resource-limited settings, particularly in Africa and in India. And the point of the study is to try to look at the most safe and also the most effective regimens to use to prevent transmission from mothers to babies of the HIV virus.
And how did you, what were the ways in which you were to accomplish this?
Well, what we've done is we talked to women who are pregnant and who have tested positive for HIV, and we asked them if they want to be in a study to try to look at the most effective ways to reduce the chance that their baby would be infected, and to also look at ways to improve their health and their baby's health. And if they're interested, we then go through a very formal process, because it's a clinical trial, of discussing, making sure they understand the study and what the commitment is over time for them and their babies. And if they're still interested, knowing what other options they have, which are the standard of care in their country, then we sign them up in terms of informed consent, and then they participate in this study. And the PROMISE study goes on during pregnancy, and then up to 2 years of breastfeeding, and then it continues to follow the mothers after breastfeeding also.
So was the study, what were the options of ways that they could avert infection, mother to child?
Right. Well, what there's been a lot of progress in preventing transmission from mothers to babies over the last 2 decades. And we started with a drug called zidovudine, and we found that that drug in 1994 actually reduced transmission in the U.S. using a fairly long regimen during pregnancy and then at birth and then after by about 2/3. So that was the first study that really showed you could give mothers drugs that are anti-HIV drugs and prevent transmission to babies, which was very, very good. Because
2/3 more than the norm.
The norm, yeah. And before we had anything, about 1 in 4 babies would be infected. So with that, they were able to reduce transmission by 2/3. And that was the first study that really showed you could use drugs to do that. Since then, there's been a lot of work by the research community to try to work with mothers and understand in resource-limited settings where perhaps the really expensive regimen that was used in the U.S. at that time couldn't be used there because the governments didn't have money to pay for that kind of a regimen, whether a simpler regimen would also work. So initially we tried things right around labor and delivery and found that actually giving a single pill to a mother at labor and to her newborn could touch transmission by cutting it to about 50%. So even a single pill could make a difference. And since then, researchers and again communities and governments have worked together to try to find regimens that are very effective, very safe, but simpler and not as complicated as the initial AZT regimen. So currently, the regimens we looked at in this study build on all the prior knowledge and research, and we really tried to look at giving a triple anti-HIV drugs to the mother versus that zidovudine regimen, but starting at an earlier time point than was possible over the last several years. So we started close to this beginning of the 2nd trimester.
For both drugs, the
for
AZT
both,
and for the...
And for the triple drugs. And then what we were really trying to look at was which is safer and which is most effective. And so today we were able to present the results of the study in terms of during pregnancy and then looking out to 2 weeks. And what we found was that using the triple drugs did give you the lowest risk of transmission and that was very important to know. It was less than 1%. We also found that giving the AZT gave you very low transmission of less than 2%. So both of them were good, but the best in reducing transmission risk was the triple drugs. So we presented that today. And then we also presented safety data today on those two regimens, whether one is safer than the other. And
so you only had like 1% failure on the whole a breakthrough?
it was 0.56%, so less than 1%.
And did you evaluate that? How many would that make it in numbers?
We had a total of about 3,500 mothers and their babies who were involved in the study. So it's a very low
total number,
risk of transmission, was only around 34.
34 people. Did you evaluate those folks as far as what are those women about what their, did you know that they actually were taking the drug, first of all?
We have used a variety of ways to try to look at that, but we do ask the women as one of the main methods. So
self-reporting.
Self-reporting is used. And then one of the things we're also in the process of doing is looking at whether the virus can be detected or not based on viral load is the term we use. And that process is underway. So we'll have a
stored blood. Stored blood, yeah.
Yeah, so we'll be looking at that too.
How do you, so there's a lot more that you're going to extrapolate from the work you.
Yeah, so the transmission data looks very strong, but we also looked at safety and presented that information today. And what we saw was that using the triple drugs, which included either zidovudine and 3-TC or tenofovir and FTC plus a protease inhibitor, that we actually had more safety events. We're using the triple drugs. So in contrast to the transmission, the safety went the other direction in terms of having low birth weight babies, the risk of that, or having a baby born early. So we're still trying to look at that and see long term whether that will have any effect on the child's survival, living longer.
So you are going to follow these folks out to what extent?
The babies we're following through 24 months or 2 years of age. The mothers will be following until 2 years after the last mother in the study delivers. So we expect probably until 2017, middle of 2017, and then we should have results on the safety and effectiveness both for during breastfeeding as well as for the mother after she stops breastfeeding, what's the best thing to do for her health.
And these are people that were not, how can I say it, suitable or not able to get access to treatment up to that point. Is that true?
The women who are in our study were women who have very high CD4 counts and are healthy, and in general, according to adult treatment guidelines, would not need treatment. But for prevention of transmission to the babies, they were eligible based on being healthy and having high CD4 counts to take in, be part of the study if they wanted to. So we consented them to participate in the study.
Did they all get drug beyond the trial or no?
They would be eligible to have drugs if they meet criteria for treatment. So that's always an option in the countries. The standard of care is available for adults and children who need treatment.
I mean, those that were on the triple drug, that was not standard of care in that country?
In terms of their CD4 count at the time we started the study, it was not standard of care.
But it now is? Or?
So now what's happened is WHO has recently come out with guidance saying that all women who are pregnant should be on triple drugs to prevent transmission, but then stay on for a lifetime. So that's the background standard of care now.
So they could stay on for a lifetime?
They could stay on for a lifetime. And what we're doing is referring the women, after they're completed the study, to the standard of care in their country.
Did you see the work that was presented on other studies? I was just thinking what your vision of, or what your opinion of some of the other studies was that were in your, for instance, in your particular section at the CROI?
I thought all the presentations were excellent at this session. There was a lot on pediatric treatment. There was a lot on ways to help adolescents adhere better, and some very interesting work in terms of diagnostics at point of care for babies to be able to tell a mother right then if the baby was infected or not. So I thought the session was great.
The diagnostics are, is that like a kit, or do you suppose? Or
yeah, it is like a kit. There's some different ones that are being looked at. All of them are being validated right now. They're not quite ready for going out for use, but they're much closer than they were like 4 or 5 years ago. There's several that are being looked at, and one was presented today, and data looked promising in terms of being able to further down the road be able to use that at a point of care to let a mother know that day when she brings her baby in if the baby's infected or not. And the good news is that now for treatment, we're able to offer treatment to infected babies very early. But with these strategies that we're using to prevent transmission, we hope to have very few, less than 2 in 100 babies infected, less than 1 in 100. So,
how quickly do they generally, show signs of being positive?
It depends on the baby. Some babies, it's very soon after birth, within the first few months. Other babies could go much longer without showing it.
Pediatric or early birth, just after birth, they have that protective immunity of some sort. Seems the mother's
it really depends on the baby. So early diagnosis is what everyone's trying to do, because the sooner you start a baby on treatment, the much better in terms of them being able to live healthy lives. So we're trying to get, as soon as you know a baby's infected, such as at 6 weeks, which would be done in resource-limited settings, they would try to test every baby by then. If they can do that, then we are hopeful that babies can get started on treatment and live very normal lives. But we're also trying very hard to test the mothers and to put her on effective treatments so that the baby doesn't become infected, either when she's pregnant or during breastfeeding. We try to cover the mother or the baby during those time periods.
Well, I appreciate very much that you've taken the time to visit with us, because it's always exciting to hear more about what the pediatric end of this research is doing. Is there anything else you might want to bring up or throw out there as?
Just that the clinical trials are very important to do, because they give you information both on safety as well as effectiveness. So we think this study was very important because it did help confirm the WHO guidelines in terms of the most current recommendations to use triple drugs for prevention.
Right.
So,
well, it's very kind of you to do this, and I thank you very much, and we wish you well.
Thank you. Good to see you.